Welcome to this explainer. Okay, if you're on an IVF journey or you're gearing up to start one, there's a word that pops up in ultrasounds that pretty much instantly spikes your heart rate: fibroids. It feels like this massive roadblock hitting right when you're ready to get going. But listen, today we're going to completely demystify the whole thing. We're diving into the actual data to clear out the confusion so you have the absolute clarity you need to navigate your options and really boost your chances of IVF success. You absolutely do not need to be in the dark about this.
So, here's our pathway to clarity for today. We'll hit the fibroid factor in IVF, why location dictates your treatment, the hard numbers on success, mapping the right approach, and wrap up with balancing time and treatment.
All right, let's jump straight into Section 1, the fibroid factor in IVF.
Right out of the gate, I want to bust a massive myth for you. Hearing the word fibroid does not automatically mean you're headed for surgery, and it absolutely doesn't mean your IVF timeline is derailed. So what are they, really? Simply put, they're just non-cancerous growths made of muscle and fibrous tissue in or around the uterus. And if you have one, trust me, you are in very good company. They are incredibly common. We're talking up to 1 in 3 women developing them during their reproductive years. Also, clinical data shows they're more frequent and often larger in women of Black, African, and Caribbean heritage. Honestly, a lot of women have them, feel zero symptoms, and only find out completely by accident during a routine scan.
So why do fertility specialists care so much if they're so common? Well, it's because during IVF, certain fibroids act like basically the ultimate antagonist to implantation. They can physically distort the uterine cavity or the lining, which makes the environment completely uneven for an embryo. They can actually reduce vital blood flow to the endometrium, trigger unwanted inflammation, and even cause the uterus to contract when it really should just be resting. And in some tricky cases, their physical size and position can literally get in the way of the embryo transfer technique itself.
Which brings us to Section 2, location dictates your treatment.
If you take away just one single concept from this explainer, make it the real estate rule. Location matters way more than size alone. Doctors use something called the FIGO classification system, which basically sorts fibroids into 3 main camps based on where they've set up shop relative to the uterine cavity. First up, submucosal. Honestly, these are the worst offenders. They bulge right into or distort the cavity. Because they have the biggest negative impact on implantation and live birth rates, the protocol is crystal clear here. They've got to be removed before IVF. Now, on the total flip side, we have subseral fibroids. These guys just hang out on the outer surface of the uterus. The evidence shows they really don't consistently mess with fertility, so routinely, no surgery needed. Then, right smack in the middle, we have the intramural fibroids. These live inside the muscular wall. They don't distort the cavity, but they can still reduce birth rates, so this is that gray area where you really need a highly individualized game plan.
Moving on to Section 3, the hard numbers on success.
Now, these aren't just dry, boring statistics. This is the ultimate map guiding your care. Let's look at 21%. Systematic reviews show there's a 21% drop in live birth rates when those non-cavity distorting intramural fibroids are present, compared to having no fibroids at all.
We also see a 15% reduction in clinical pregnancy rates with those exact same non-distorting intramural fibroids. So even when they aren't actively bulging into the cavity, they can still drag down your odds.
But hey, here is the absolute game changer: 64%. You have a 64% higher chance of an ongoing pregnancy or live birth after a myomectomy, that's the surgical removal of the fibroids, for intramural fibroids before starting IVF. That is huge, actionable, and super uplifting data.
And if you're kind of wondering, okay, but how much can I actually trust these numbers? Well, they're pulled from a massive pool of 6,087 analyzed IVF cycles across a bunch of different studies. That's enough data to fill a stadium. It's not some tiny sample size. It's incredibly robust evidence that should give both you and your doctor a ton of confidence in your treatment plan.
All right, Section 4, mapping the right approach.
If you've just been diagnosed with a fibroid, seriously, take a breath. Don't panic. Your medical team has a really structured, proven protocol to figure out the exact next steps across 4 assessment stages. Step 1 is a transvaginal ultrasound. It's your standard baseline to spot the number, size, and rough neighborhood of the fibroids. Step 2 zooms in, a saline infusion sonography or a hysteroscopy. This is absolutely critical, right? Because it confirms if the uterine cavity is distorted, which, as we know, is the big deal breaker. Step 3 is an MRI, and that's usually saved for precise mapping of really complex or large fibroids before a surgery. And Step 4 is the MDT discussion.
That's basically where your fertility specialist and a surgeon put their heads together to build the absolute best custom treatment plan for your body.
Now, if intervention is actually needed, here are your main options. For those submucosal fibroids, doctors usually go with a hysteroscopic myomectomy. It's minimally invasive, usually just a day procedure, and takes about 1 to 3 months to recover from. For the larger intramural ones, you might be looking at a laparoscopic or open myomectomy. Now, I know that carries a heavier physical and emotional weight, mostly because the recovery takes about 3 to 6 months for your uterus to truly heal. Then there's watchful waiting, literally no delay at all, which is perfect for those small, non-distorting fibroids. Oh, and I really want to point out uterine artery embolization at the bottom there. While it's used a lot in general gynecology, it can actually reduce ovarian reserve, so it is generally a hard no for fertility patients.
Finally, Section 5, balancing time and treatment.
This right here is where hard medical data meets the messy reality of your biological clock and your personal life. Choosing to pause for surgery is a massive deal, and your doctor will weigh this with you very carefully. Time is huge. If you're dealing with advanced maternal age or diminished ovarian reserve, a 6-month surgical delay just carries a completely different weight than it does for someone a bit younger. They're going to look at the fibroid's growth pattern, like is it just chilling there or is it growing fast? They'll look at your symptoms too, like heavy bleeding or pain, which might mean surgery is happening regardless of IVF. And of course, they have to weigh surgical risks like uterine scarring, which could affect things down the road. It's a really delicate balancing act.
To give you some absolute clarity, let's look at the totally opposite ends of this decision matrix. On one side, submucosal. If it distorts that cavity, the rule is pretty much set in stone. Get it out before IVF and let the endometrium heal. On the far other side, subserosal only. If it's strictly chilling on the outer surface, zero fertility surgery is needed. You're good to just proceed right into IVF.
And to clear up that super tricky gray area in the middle, the intramural fibroids. If the fibroid is 4 centimeters or larger or it's actively growing, you and your doc are going to need a serious sit-down to weigh surgery versus going straight to IVF. But if it's small, totally stable, and causing absolutely zero cavity distortion, well, usually IVF can just roll right ahead without any delays while they keep a close eye on it.
All right, let's do a quick recap of the biggest takeaways from our explainer today. Remember that real estate analogy. Location, location, location. That is what drives the impact on your IVF success. Submucosal fibroids? Gotta go. Intramural? That requires a very personalized chat about the risks. Subserosal? Generally, they need absolutely no treatment. But the most important thing to remember is that every single case is uniquely reviewed based on your age, your ovarian reserve, and what your specific scans show.
So I want to leave you with this one vital question to take right back to your fertility specialist. Does your specific fibroid location actually require a pause, or are you clear to confidently begin your IVF cycle? You know, you've got the knowledge and the framework now to go have that exact conversation and map out your unique next steps. Thank you so much for hanging out with me for this explainer, and I am sending you all the absolute best on your journey ahead.